Your doctor checks your blood pressure, looks at the screen, and says the number out loud. Maybe it is 138 over 78. Maybe it is 142 over 80. And then they say something like, "We should get that down closer to 120. You nod. You go home with a prescription or a stronger dose of the one you already have. You do what you are told. That is the moment this conversation is really about. Not the prescription, not the number on the screen. The assumption behind the advice, the idea that 120 over 80 is the target every adult should be aiming for, regardless of age, regardless of what is happening inside their arteries, regardless of what their body actually needs right now. That assumption has been guiding treatment decisions for decades. And for adults over 60, it may be quietly causing more harm than it prevents. My name is Dr. Warren Hung, and I have been practicing medicine long enough to watch this debate shift more than once. I work with patients across a wide age range, and one of the most common patterns I see in older adults is this. They are being treated for a number rather than for their actual cardiovascular health. The two things are not always the same. If you are new here, subscribe. I put out videos on health topics that matter to people who want to understand what is actually happening in their body, not just what they are told to do about it. Now, back to that number. The 120 over 80 target has been a standard reference point in medicine for a long time. It became even more widely used after large clinical trials suggested that lowering systolic blood pressure, that top number below 120, reduced the risk of heart attack and stroke. That finding got picked up fast. Guidelines shifted. Doctors tightened their targets. Patients started getting more aggressive treatment. The problem is that the research behind that shift was done on a specific group of people under specific conditions. And when those findings got applied broadly to older adults, to people with arterial stiffness, to patients with different kidney function and different cardiovascular profiles, the results did not always look the same. In some patients over 60, pushing blood pressure down to 120 improved outcomes. In others, it made things worse. Significantly worse in ways that do not always make the front page of a health article. Falls, kidney decline, dizziness, fainting, episodes of confusion. These are not rare side effects from bad luck. They are documented consequences of blood pressure being driven too low in a body that has aged past the point where that target makes biological sense. And the reason this happens is not complicated once you understand what aging actually does to your arteries. The cardiovascular system at 65 is not just an older version of the cardiovascular system at 35. It has changed structurally. The vessels themselves have changed. The way the heart pushes blood, the way the arteries respond, the way organs like the brain and kidneys receive their blood supply, all of it shifts with age in ways that make a single universal blood pressure target genuinely difficult to apply safely. This is not a fringe position. Cardiologists, nephrologists, and geriatricians have been raising this concern for years. The debate inside medicine about the right blood pressure goal for older adults is real, ongoing, and more nuanced than most patients ever hear about in a standard appointment. What you are usually told is a number. What you rarely hear is why that number may not apply to you specifically, what your arteries are doing that changes the calculation, or what the signs look like when treatment has gone too far in the wrong direction. That is what this video is going to cover. We are going to start with the biology, what actually happens to arteries after 60, and why it matters so much for how pressure should be managed. Then we will look at the evidence, including where it holds up and where it gets misapplied. And we will finish with what the real goal looks like for someone your age, and the specific questions worth raising with your own doctor. Understanding why the standard target can be wrong is the first step. Understanding what your arteries are doing right now is where it starts to get clear. To understand why the standard blood pressure target becomes complicated after 60, you have to understand what is happening to the vessels themselves, not in abstract terms, in physical, structural terms. When you are young, your arteries are flexible. The walls of those vessels can stretch and recoil with every heartbeat. When the heart pumps, the arteries expand slightly to absorb the pressure wave, then spring back to push blood forward. That elasticity is doing a lot of quiet work. It is smoothing out the pressure spikes. It is protecting the smaller vessels downstream, the ones feeding your kidneys, your brain, your eyes. And it is making the heart's job easier because a flexible vessel gives way rather than resisting. That is how the system is supposed to operate. As the decades pass, something changes in the walls of those arteries. The elastic fibers that give vessels their stretch begin to break down. Collagen, a stiffer structural protein, takes over more of that wall space. Calcium deposits accumulate. The vessel wall thickens slightly and loses its ability to recoil the way it once did. This process has a name, arterial stiffness, and it is not a disease in the traditional sense. It is a normal part of cardiovascular aging that happens in virtually everyone to some degree. The consequences of that stiffness are not just mechanical. They ripple through your entire blood pressure picture. When a stiff artery can no longer absorb and dampen the pressure wave from a heartbeat, that wave travels faster and harder through the vascular system. The systolic pressure, the top number on your reading, tends to climb because the heart is pushing against a vessel that does not give way. Meanwhile, the diastolic pressure, the bottom number, often stays flat or even drops because the vessel is no longer storing and releasing energy between beats the way a flexible artery does. This produces a pattern that is extremely common in adults over 60, isolated systolic hypertension. The top number is high, sometimes well above 140, while the bottom number is normal or even a little low. And the gap between those two numbers, which doctors call pulse pressure, widens. This is where a critical mistake often gets made. When a doctor sees a systolic reading of 148, the instinct is to treat it down. That is what guidelines suggest. That is what training reinforces. But in an older adult with stiff arteries, that elevated systolic reading is partly a mechanical consequence of vascular aging, not purely a sign that the system is running dangerously hot. Treating it aggressively as if it were the same reading in a 40-year-old can create a completely different set of problems. Here is why. The organs in your body, your brain, your kidneys, your heart muscle itself, rely on adequate blood pressure to receive their blood supply. This is called perfusion. In a young person with flexible arteries, the system can maintain perfusion across a wider range of pressures because the vessels adapt. In an older adult with stiff arteries, that adaptive range narrows. The organs become more dependent on a higher baseline pressure to keep blood moving through them reliably. Think of it this way. Flexible arteries are like a rubber hose. Squeeze it anywhere, and the pressure equalizes quickly throughout. Stiff arteries are more like a rigid pipe. The pressure has to be maintained at a higher level at the entry point just to push adequate flow through to the other end. Drop the pressure at the entry point too much, and flow to the far end suffers. When blood pressure is pushed too low in someone whose arteries have stiffened significantly, the brain is often the first organ to feel the consequence. Blood flow to the brain becomes insufficient during position changes, standing up from a chair, getting out of bed in the morning. The result is dizziness, lightheadedness, and in older adults, a sharply elevated risk of falls. Falls in people over 65 are not minor events. They are a leading cause of serious injury and hospitalization. The kidneys face a similar problem. They filter blood under pressure. When that pressure drops too far, filtration slows. Kidney function declines. Patients who are already managing early chronic kidney disease can see their numbers worsen significantly when blood pressure treatment is pushed too aggressively. And then there is something researchers have been paying closer attention to in recent years: cerebral perfusion. The brain needs consistent, adequate blood flow to maintain cognitive function. Several studies have raised the question of whether blood pressure that is too low in older adults, particularly those with established arterial stiffness, may actually accelerate cognitive decline rather than protect against it. The data is still developing, but the signal is serious enough that it has shifted how many geriatric specialists think about treatment targets in their older patients. None of this means blood pressure does not matter after 60. High blood pressure remains a genuine risk for stroke, heart attack, and kidney damage at any age. That is not in dispute. What is in dispute, and what the clinical evidence has made increasingly clear, is whether the same numerical target that reduces risk in a 50-year-old reduces risk in a 72-year-old with stiff arteries, early kidney disease, and a history of dizziness on standing. The biology says the answer is not always yes. And the studies, when you look at them carefully rather than at the headline numbers, say the same thing. The study that changed blood pressure treatment guidelines more than any other in recent decades is called the SPRINT trial, Systolic Blood Pressure Intervention Trial. It ran across more than 100 clinical sites in the United States, enrolled over 9,000 adults, and asked a direct question. Does pushing systolic blood pressure below 120 reduce cardiovascular events compared to a target of 140? The answer, according to the trial's primary results, was yes. Significant reductions in heart attack, heart failure, and cardiovascular death. The findings were compelling enough that the trial was stopped early. Guidelines were updated. The push toward tighter targets accelerated across medicine. And that is exactly where the trouble began. Not because the SPRINT trial was wrong, the data it collected was real, but because of what happened next, the way those findings were interpreted, generalized, and applied to populations, the trial was never designed to represent. Look at who was enrolled in SPRINT. Participants had to be at least 50 years old with elevated cardiovascular risk. But the trial specifically excluded people with diabetes, people with a prior stroke, and people living in nursing homes or assisted living facilities. It also excluded patients with significant cognitive impairment and those with certain kidney conditions. These exclusions were not arbitrary. They were methodological decisions designed to isolate a clean signal in a controlled population. The problem is that the average 70-year-old, sitting in a primary care office in the real world, does not look like a sprint participant. They may have diabetes. They may have had a minor stroke. They may be managing early dementia alongside their blood pressure. They may already be on 4 or 5 medications. They may have a history of falls. When the trial's findings lower is better, push toward 120 got applied to that real-world patient. The results were not always what the headline promised. The evidence for this is not anecdotal. A substantial body of research has examined what happens when older adults, particularly those over 70 and 75, are treated to very low systolic targets. What that research consistently shows is a phenomenon called the J-curve effect. At a certain point, as blood pressure is driven lower and lower, the risk of adverse events stops falling and starts rising again. The curve bends back up. Cardiovascular events increase, kidney function worsens, mortality risk climbs. The J-curve is most pronounced at the extremes, and it is most dangerous in older adults with arterial stiffness, low diastolic pressure, or underlying organ vulnerability. Driving a systolic reading below 120 inches, an otherwise healthy 5-year-old, may well reduce risk. Driving the same number in a 7-4-year-old, with a diastolic pressure already sitting at 62, is a fundamentally different clinical decision, and one that carries real consequences if made without accounting for the individual in front of you. This is the mistake that causes harm, not malice, not negligence in the traditional sense. It is the mistake of treating a number on a screen as if it tells the whole story, and applying a population-level target to an individual whose biology has moved outside the range that target was built for. The consequences show up in predictable ways. Orthostatic hypotension is one of them. That is the drop in blood pressure that happens when a person stands up quickly. In a healthy cardiovascular system, the body compensates, fast vessels constrict, heart rate adjusts, pressure stabilizes. In an older adult on aggressive blood pressure medication, that compensation is blunted. The pressure drops, the brain does not get adequate flow for a moment, and the person feels dizzy or loses their footing. In a 7-5-year-old, that fall can mean a fractured hip. A fractured hip at that age carries a 1-year mortality rate that most people would find alarming if they saw it written plainly. Acute kidney injury is another consequence. The kidneys regulate their own blood flow through a process called autoregulation. They can maintain filtration across a fairly wide range of pressures by adjusting the diameter of the vessels entering and leaving the filtration units. But that autoregulation has limits, and in older kidneys that have already lost some functional reserve, those limits are reached sooner. Push systemic blood pressure too low, and the kidneys simply cannot compensate. Filtration drops, waste products accumulate, creatinine levels rise. What started as an effort to protect the cardiovascular system ends up accelerating the kidney disease that was already quietly developing. And then there is what happens to the brain. Several studies following older adults over time have found that lower blood pressure, particularly diastolic pressure, falling below 60 or 65, is associated with faster cognitive decline and greater white matter changes. On brain imaging, white matter changes are not benign. They represent areas of the brain where blood supply has been insufficient long enough to cause structural damage. They are associated with memory problems, slowed thinking, and increased dementia risk. This does not mean blood pressure treatment causes dementia. The relationship is complicated, and researchers are still working through the direction of causality. But it does mean that the assumption embedded in current treatment culture that lower blood pressure is always better for the brain is not supported by the evidence when applied to older adults across the board. What the evidence actually supports is something more careful. It supports individualized targets. It supports treating the patient rather than the number. It supports asking not just what the reading is, but what the person's arteries look like, what their kidney function is, what their fall history is, what their diastolic pressure is doing, and what the cost of aggressive treatment might be for this specific person at this specific point in their life. That is a harder conversation to have in a 10-minute appointment, but it is the right conversation. And knowing what to ask going into that appointment is something every adult over 60 deserves to understand before they sit down in that chair. The answer to what the right target actually looks like is more specific than a single number, and more useful than anything a blanket guideline alone can offer. There is no single blood pressure number that is correct for every adult over 60. That is not a vague answer. It is the most accurate and honest thing the evidence allows anyone to say on this topic right now. What exists instead of a universal target is a framework, a set of individual factors that, when considered together, point toward a range that is likely to reduce risk without creating new harm. Understanding that framework is what allows you to have a genuinely useful conversation with your doctor, rather than a passive one where a number gets adjusted and you leave without understanding why. So let us go through what that framework actually looks like. The first factor is age itself, considered alongside functional status. Adults between 60 and 70 who are otherwise healthy, active, and without significant arterial stiffness or organ compromise are generally reasonable candidates for a systolic target in the range of 130 or below, provided that target is reached gradually and tolerated without symptoms. That is consistent with current evidence and does not carry the same risk profile as aggressive lowering in more vulnerable patients. Adults over 75, however, occupy a different category in the research. Multiple studies focus specifically on this age group, including analyses from the HYVET trial, which looked at hypertension treatment in adults over 80, found that a systolic target closer to 140 to 150 was associated with better overall outcomes than pushing toward 120. The benefit of lower targets in this group was less consistent, and the risk of harm from overtreatment was meaningfully higher. That is not a small distinction. It is a 20 to 30 point difference in what the target should be, depending on the individual in front of the doctor. The second factor is diastolic pressure. This one gets far less attention than it deserves. If your diastolic reading, the bottom number, is already sitting at 65 or below, while your systolic is elevated, that is a wide pulse pressure. It is a sign of significant arterial stiffness. And it is a strong signal that aggressive treatment of the systolic number carries real risk, because further lowering will likely drag the diastolic number down with it into territory where organ perfusion becomes compromised. A diastolic reading below 60 inches, an older adult, is a threshold that warrants serious caution, not more aggressive medication adjustment. The third factor is kidney function. Your estimated glomerular filtration rate, your eGFR, tells your doctor how well your kidneys are filtering. If that number has been declining, if you are already in the moderate range of chronic kidney disease, the target for your blood pressure needs to account for the fact that your kidneys have reduced autoregulatory capacity. They cannot protect themselves as well against pressure drops. Your cardiologist and your nephrologist, if you are seeing one, should be aligned on your target, because what protects your heart may stress your kidneys if the coordination is missing. The fourth factor is your history with symptoms. This one is practical and important. If you regularly experience dizziness when you stand up, lightheadedness in the morning, or episodes of feeling faint, those are not incidental complaints. They are clinical data. They suggest your blood pressure is dropping to a level your brain cannot consistently compensate for during positional changes. That symptom pattern in an older adult on blood pressure medication is a clear signal that the current regimen deserves review, regardless of what the resting reading on the monitor shows. The fifth factor is frailty. Frailty is a clinical concept that goes beyond age. It includes muscle loss, slowed gait speed, unintentional weight loss, exhaustion, and reduced grip strength. Frail older adults have significantly less physiological reserve to buffer the effects of blood pressure that is pushed too low. Several geriatric medicine guidelines now explicitly recommend higher blood pressure targets, some as high as 150, systolic for patients who meet criteria for frailty, precisely because the risk of falls and functional decline outweighs the cardiovascular benefit of a tighter target in this group. Taken together, these five factors, age and functional status, diastolic pressure, kidney function, symptom history, and frailty, form the real framework for making a blood pressure decision in an adult over 60. None of them appear on the standard blood pressure monitor. All of them matter. Now, here are the specific questions worth raising with your doctor at your next appointment. Ask what your target range is, and ask why that specific range was chosen for you. A good answer will reference your individual profile, your age, your kidney function, your symptom history. A less useful answer will only reference a guideline number without connecting it to your specific situation. Ask what your diastolic reading has been trending toward over the past year. If it has been falling while your treatment has been intensified, that is worth discussing openly. Ask whether your blood pressure has been checked in both the sitting and standing positions. This is called orthostatic blood pressure measurement, and it is the most direct way to assess whether your medication is causing dangerous drops during position changes. It takes about 2 minutes and is often skipped entirely. Ask about your eGFR trend. If your kidney filtration numbers have been declining in the same period that your blood pressure treatment has been tightened, the timing of that decline is relevant information. And if you have had any falls, near falls, or episodes of dizziness in the past 12 months, say so explicitly. Do not assume your doctor already knows. In a busy clinical setting, that history does not always make it into the chart in a way that influences prescribing decisions. Naming it directly changes the conversation. The goal of blood pressure treatment at any age is not a number for its own sake. It is the preservation of function, cardiovascular function, kidney function, brain function, physical independence. For a 40-year-old, pushing hard toward 120 systolic usually serves that goal well. For a 72-year-old with stiff arteries, a diastolic reading of 63, and a history of morning dizziness, the same target may be working directly against it. Your body at 60, 70, or 80 is not the same body that was studied in the trials that built the standard guidelines. That does not mean treatment is wrong. It means treatment needs to fit the person receiving it. If this video gave you something concrete to bring to your next appointment, share it with someone you know who might need it. And if you want more videos that go this deep on topics that actually affect how you age, subscribe. There is a lot more ahead that is worth understanding.